All right, good evening and welcome to today's discussion. This is day four of our group discussions for internal medicine primaries. And the question you're seeing on the whiteboard is the first question for the day. I believe you guys can see the whiteboard, right? So that's the question of the day. Um, which antihypertensive is known to cause dysgeusia? So attempt the question in the group chats. I'll still post it there to make it easy to track. The options include lisinopril, let me make this thing bigger. Lisinopril, amlodipine, metoprolol, and hydrochlorothiazide. Okay, so I agree with you, Doctors Junior and Sam. It's most likely lisinopril. So, what are the other side effects of lisinopril? During medical school, there's a popular mnemonic that we used as the side effect of AC inhibitors. Okay, and it goes captopril, right? So C is for what? There's cough, angioedema, protein, potassium, like hyperkalemia. What's T for? O is edema. R is renal, involvement. What's the I and what's the L? So let's see. Captopril, mnemonic. So there's cough, angioedema, potassium changes. Yeah, usually it causes hyperkalemia, that's increased potassium level, because it acts through the renin-angiotensin aldosterone system, which affects aldosterone. We know that as aldosterone leads to salt absorption and potassium excretion. So if you inhibit aldosterone, you are going to cause sodium excretion and potassium reabsorption. So okay, so you now have hyperkalemia. Taste changes, it causes changes in taste. This is also another common question they test you on, okay, in exam. So which are the medications that cause changes in taste? Metronidazole, metallic taste, okay, lisinopril, like AC inhibitors, metronidazole, all those type of drugs. So hypotension, I know there is edema somewhere, sha. That's reduced blood pressure. They use that O to indicate it. Pregnancy changes, rash, increased renin, which is expected, and then low angiotensin too. Okay, all right. The Sorry, what I showed just now, did it show? What's showing on my live stream? Okay, so All right, let me go to the next question. Who is this now? Please stop controlling the screen now. Dr. Debbie and Ayokunle, stop controlling the screen. All right. So, which of the following? See now, somebody is drawing something here. Which of the following is a long-term complication of chemotherapy? Option A, neutropenia. Option B, infertility. Option C, anaphylaxis. Option D, gastrointestinal upset. Long term. Someone is still drawing things here. Please, now you guys should stop drawing. Don't draw anything on the screen. It's obstructing the question. So we have people choosing options B, which is infertility. Uh, we have someone choosing, okay, two-person choosing option A, which is neutropenia. All right, so we'll go for infertility. So infertility. All right. The next question. We know that we know that chemotherapy tends to affect rapidly dividing cells. So it's going to affect cells of the GI and cells of the gastrointestinal tract. So in the short term, it can lead to nausea, vomiting, diarrhea, gastrointestinal upset. It affects cells of the skin because they are also rapidly dividing and rapidly progressing, right? So it can cause skin changes, nail changes, hair loss, all those things, right? That's in the short term. Then it can also cause can also affect the gonads, right? So the testes and the ovaries, because they are also rapidly dividing cells. So in the short term, it can affect them, but in the long term, for example, a woman may stop having her menstruation when she's taking chemotherapy and things like that. A man may start having low sperm count, erectile dysfunction, reduced testosterone levels. But in the long term, it can now finally lead to infertility. So chest drain insertion, the primary concerns. This question tests your knowledge of, you know, what will be your primary concern. I've I mentioned this thing in passing. the other day. So, what will be your primary concern when you insert the chest drain at the fourth intercostal space? Option A is pneumothorax.
Pneumothorax.
Option B is damage to intercostal vessels. Option C is hemothorax. Option D is incomplete drainage.
I'll go with A.
This question already gives you away the site of intercostal drainage, because that could be another test that you can have. You can have a test asking you what's the best site for chest tube insertion. Okay, so that's the fourth intercostal space, mid axillary line. And you're going to place it of the on the top of the rib, right? Not on the bottom of the rib. So you're going to place it on the top of the fifth rib, not on the bottom of the fourth rib, because you're trying to avoid those vessels which are hidden inside. So that's also another possible question that can be asked about that. Is there anyone here who has an issue with signing in? Because this is your opportunity for me to guide you. If you, I was expecting the person to come on time so that we'll discuss it, but the person didn't show up. All right.
Nobody.
So damage to intercostal vessels, that's the answer. The next question. What causes the
Sorry,
dicro?
sir. Is it damage to intercostal vessels? Because at whatever point you put it, you can damage the intercostal vessels if we don't go through the upper margin. I'm thinking that fourth intercostal space and mid axillary line should be more of incomplete drainage.
What?
I'm thinking option D too should be there, incomplete drainage, since the tube is up there very high. Because if it is damage to intercostal vessels, any intercostal space at all that you choose, if you don't go for the upper margin, you can still damage the intercostal vessels.
Mhm. So where are you supposed to insert it?
No, I'm just thinking like is option D too not to be considered?
No.
You are looking for the best option. The exam asks you for the best option for every question. So sometimes you can even have many options that may be correct, but you're looking for the best option. So that's the best option. Anytime you're inserting a chest tube, the only thing that, the fact, the major thing that will be on your head is not incomplete drainage. Major thing that will be on your head as you're inserting it, because the question is saying when inserting, not later. What are the complications of insert? No, it's saying when inserting. As you're inserting that chest tube, what is that thing on your mind? It is option B that is on your mind. That's what you'll be looking
Yeah.
out for. That's
Damage
what
to
you see
intercostal.
the technique of anyone who has inserted chest tube. That's what you are trying to avoid as you are inserting it. And that's what the question is testing. So that's the best option.
Okay.
Okay. So next question here says um, what causes the dicrotic notch in the arterial and pressure waveform? Closure of the mitral valve, closure of the aortic valve, opening of the aortic valve, opening of the pulmonary valve. So
This
you
is
guys can
dicrotic.
attempt the question, but we'll need to look for an image
Mhm.
dicrotic notch. aortic pressure curve. Okay. So apparently there's a curve that is uh, tracing the aortic plotting the aortic pressure against time in seconds. Okay. Yeah, plotting the aortic pressure against the time of the cardiac cycle in seconds. So a waveform like is usually formed, and within that waveform there's a slight notch. Let me see if I can show you the image. So there's a slight notch that is shown. Can you guys see the screen?
No.
And so on that screen, there's a slight notch that is shown. Okay. And that notch indicates the dichrotic notch. And that dichrotic notch, coincides with the time when the valve is getting closed, like the aortic valve
Aortic, aortic
closes.
valve.
So
Yes.
that's option what? Option B.
Option B.
Yeah. The waveform is something like this. Let me see if I can. Then this is a notch and goes down like this. So something like this. This is the y-axis is aortic pressure, and the x-axis is the time. Okay, so this place is known as the dichrotic notch. All right, so that's basically it. So closure of aortic valve. Remember that it's the aortic arterial pressure, so it's closure of the aortic valve that causes that notch there. All right, the next question. Hmm. This is a simple question. Okay, test your knowledge of renal medicine. So, what way will you differentiate cystitis from pyelonephritis when you do a urinalysis? What would you see that will make you consider a cystitis above a pyelonephritis? Okay, we have option A, nitrites, option B, leukocyte esterase, option C, WBC casts, option D, hematuria. Yes, all the options are going to be there on cystitis except white blood cell casts. When you see any form of casts, it implies that whether it's red blood cell cast, white blood cell, like implies something that is coming from higher up from the kidneys. Okay, so white blood cell cast is the answer. This is a very important question here for both West Africa and national candidates. You keep seeing this being recurring. It's a recurring theme in all the exams. They'll test your knowledge of, you know, uh, the blood supply of the heart. So before I put up this question, um, I'm going to try to demonstrate it. Okay, doctor, your mic is noisy. So I'm going to try to demonstrate it. Let me see if I can make a good one. Okay. So bundle by bundle. Okay, so there are going to be two blood vessels here. How do I divide this thing now? All right. So this is the right side of the body. This is the right side of the body, and this is the left. So this is left, and this is right. This place I'm going now is pointing towards the apex, right? No. Okay, so this is the left anterior descending, the left aortic, the left LAD. Okay, so the left coronary artery, I mean, you can see it's coming from the aorta. This is the aorta actually. This is the aorta, right? And the aorta has cusps. So the left aortic cusp, the right aortic cusp, and then there should be another one that I think there are three cusps. There should be another one, but that one doesn't matter for what we're discussing. So from one of the cusps, the one on the left coronary artery is going to come from it. Okay, and as that left coronary artery leaves the cusp of the aorta, as it's coming down, it's going to give off a branch, which is known as the left circumflex. Okay, but before it really becomes circumflex, it's going to first of all give off a branch called the left marginal artery. So left marginal artery. Okay, then here it will continue as left anterior descending, LAD. Okay, then continue here. Okay, left coronary artery. Continue behind it. That's why I use that dotted line to show that it's going behind. Okay, it's going behind as the left circumflex artery. This is anterior. This is left anterior descending, which points goes towards the apex. Okay, and then comes here as left circumflex, but it's not yet fully left circumflex until it gives off that left marginal artery, which supplies the left border of the heart. Okay, and then it now turns behind, now goes behind to now form the left circumflex artery, or the circumflex artery, because it's only the left that has a circumflex. Okay, and comes here behind to anastomose with something that I'm going to show you now. So the right coronary artery is coming from the other cusp, from the right side. Okay, hope you are listening very well, so that once I pose the question,
Sorry,
answer me.
sorry, because I'm not the only one seeing the previous screen. The screen I see is dichotic notch. I'm not seeing this one that you're talking about.
That means you scrolled. You have to scroll down. And if you are saying that, but scroll down. I'm down now. This is like a page. This whiteboard is like a page. So if you scroll up, you'll see what we did before. If you scroll down, you'll see what we are doing now. Okay.
Okay. Go.
So this is the right coronary artery. It comes from that right part of the cusp. It comes this way, right? It gives up a right marginal artery. So this is called the right marginal artery. And then continues behind as the right coronary artery, where it gives off a branch that will what? Anastomose. Who is this? Who is sharing screen? Please end this your screen you're sharing. You're obstructing our discussion. Who is this person? Dr. Swago. Stop sharing your screen now. I don't want to remove you. Stop sharing your screen. Off your screen sharing. So the right coronary artery so it now goes behind. Remember that there was a branch that was left off by the circumflex artery. Okay, it gives off a branch that will come and anastomose with that one. Why it continues down? So it gives off a branch that will go and anastomose with this one. Remember that everything about the body is about anastomosis. And then this one is now coming down. So this one that is coming down is called right posterior descending artery. This one is called left anterior descending artery. Why this one is called right posterior descending artery. So that one behind. All right. So please don't draw anything. Don't draw anything, doctor. I can see you. Dr. Mustafa, don't draw anything. Okay, so so this is just like the baseline of the blood supply of the heart. Okay, so with this in mind, right? With this in mind, the only other thing to take note of is that which parts of the heart are being supplied by each part of these things. So based on where the vessel is, you can actually predict. If you know the anatomy of your heart and everything, you can actually predict which one is supposed to be in which place, right? So based on the anatomy of the heart, we expect based on the anatomy of the heart, we expect the left coronary artery to supply the left side of the heart and the anterior and the left side of the heart, including the apex, right? Including most of the apex. And then we expect the right coronary artery to supply the posterior and the right side of the heart. Okay, so that's basically, so if you can think of which part of the heart is going to be posterior and which part of the heart is on the right side, that will tell you which parts the right coronary artery will supply. And also, the SA node is being supplied by the right coronary artery. Remember, the SA node is coming, this is the superior vena cava, this vessel here, and this is the inferior vena cava, right? So the SA node is coming from just the angle between the inferior and the superior vena cava. So somewhere here, let me say somewhere here, right? So we expect that the vessel that is on the right is going to be the one that is supplying it. So somewhere here, let me just mark it with X. Let me use another color, say blue color. Mark it with X. Maybe it's somewhere here. That's the SA node. Okay, so we expect that the SA node and the AV node is running along this line I'm drawing here. Is actually supposed to be where the septum is going to be, right? So this and the left coronary artery, the left anterior descending, is running along the septum anteriorly, while the right posterior descending is running along the septum posteriorly. Okay, so the AV node is running within that septum too. Okay, so SA node, AV node, and they are both on the right, right? So we expect the right coronary artery to actually be the one supplying both the SA node and the AV node. Okay, so there's something about the heart, the rule of 70-20-10, which says that in 70% of patients, the AV node is going to be supplied by the right coronary artery. You know, in medicine, there is no absolute. So in 70% of patients, in 20% of patients, it's going to be supplied by left coronary artery. In 10% of patients, it's going to be supplied by both right coronary artery and left coronary artery. So this anatomy is very important because it's a recurring question and there's no year where you will not get a question on this. Okay, so let's now see. If there's any other thing I missed, maybe if you see a question, we'll catch it. This whiteboard can actually be downloaded. So I'll see how I'm going to download it for you guys after the discussion. I just discovered it can be downloaded, so we'll not be missing out on many things that we discussed. Someone has gone up and deleted the questions. Well done. Clap for yourself. Okay, so the posterior descending artery typically arises from which coronary artery? Left anterior descending artery, left circumflex artery, right coronary artery, and marginal artery. Okay, I'll come. Let's finish this one. So you guys are going for option C, which already explains itself, because that's posterior descending artery is actually right posterior descending artery. So they just remove the right there so that to just make it a little bit hidden. So it's coming from the right coronary artery. It's a branch, it's a continuity, it's the final branch of the right coronary artery. Okay, and remember that the reason why this right posterior descending is coming towards the apex is that it's going to anastomose again with the left anterior descending here. So the reason why you have all this anastomosis is that in case, because we know that the heart is prone towards heart attacks, right? So if a person has a heart attack, what will happen? What happens when a person has a heart attack? It means the blood vessel, one of these blood, in fact, that's the clinical significance of all these things that we are discussing. That's why you have to know this anatomy to a T. Because if a patient has a heart attack, right, what happens is that the blood supply to a particular part of, remember this is blood supply. So the blood supply to the particular part of the heart where that vessel is supposed to supply is not going to be available. And what happens when a part of the body doesn't get blood supply? It dies. Okay, that's what we call ischemia. It starts with ischemia, which means it's not getting adequate blood supply. And then if that prolongs after a few hours, it becomes infarction, which means it's totally dead. Necrosis occurs and you have infarction. So that part of the what type of infarction? These are another question you can get in pathology. It's going to be a coagulative infarction. Okay, so you have a coagulative infarction occurring in the heart, in that part of the heart. Let's say is the clinical significance. The left anterior descending is the commonest artery that is affected by, a heart attack, myocardial infarction. When we say heart attack, it's actually myocardial infarction, right? So the left anterior descending, this one here, is the commonest artery being affected by a heart attack. Okay, so let's say this artery now was affected and it's being obstructed. The right posterior descending is going to try to send blood to the apex, because the apex is supposed to be the which chamber of the heart is going to be the apex. That's the left ventricle. This apex you are seeing here is the left ventricle. So the right posterior descending, because of this anastomosis, is going to try to make up for it, although it will not cover everything, but it's going to try to salvage some things there. So the person that was asking me, so I should come again for the what do you call it? The 70-20-30 rule, 70-20-10 rule. See, the AV node is here, like I said earlier, and the AV node, Dr. Hillebo, please move your cushion. The AV node is going to be supplied by the right posterior descending artery. Okay. So in 70% of cases, that AV node is going to be the supply from it is going to be coming from that right posterior descending artery, which is actually a branch of the right coronary artery. So in 70% of cases, the AV node is going to be supplied by the right coronary artery. In 20% of cases, the AV node is going to be supplied by the left coronary artery. Okay, and then in 10% of cases, the AV node is going to be supplied by both. So that's like that's 70-20-10 rule. All right. So the answer to this question is right coronary artery. So they call those 70% of cases, they call them right dominance. Right dominance. The other one is left dominance, and the third one is codominance. When it is both, it's codominance. So it's an MCQ. All right, this question, Minkowski sign. What does it imply? What does it stand for? So which condition is going to lead to a positive Minkowski sign, including pemphigus vulgaris, which is option A. Option B, bullous pemphigoid. Option C, Eudemia multiforme. Option D, psoriasis. So I want us to ask everybody. So like when you apply gentle pressure on the skin, if the epidermis just, just gentle, it's just a slight touch, and then the epidermis just sloughs off very, very easily with just a little touch. Okay, that's positive Nikolsky sign, and that implies that, there's an intraepidermal blister. So you see it in pemphigus vulgaris, which is like an autoimmune disease. Pemphigus foliaceus, staphylococcal scalded skin syndrome. Okay, bullous pemphigoid, because it is not a pemphigus. Pemphigoid means it's like pemphigus, but it's not pemphigus. And the difference actually is that this in bullous pemphigoid, the lesion is between the, is much lower down. So it's like between the dermis, between the epidermis and the dermis, or rather between the dermis and the subcutaneous tissue. So it's far down. So that epidermal sloughing is not going to happen. Okay. But unlike in pemphigus vulgaris, where the lesion is intraepidermal, so it's just there in the epidermis, maybe between the layers of the epidermis, or just between the epidermis and the dermis. So once you just touch it, the epidermis can easily slide off, showing that it's a positive Nikolsky sign. All right. So option A is the answer. You also see it in staphylococcal scalded skin syndrome. Hypopigmentation of hair is not seen in which condition? Option A, vitiligo. Option B, albinism. Option C, kwashiorkor. Option D, pellagra. Hypopigmentation of hair is not seen in which condition? This question is an except question. It's not seen. So it means it's seen in everything except one. So are you telling me that the skin is not hypopigmented in albinism? For those who are choosing albinism, that should be like the one that you are not even going to choose. Do you know the meaning of vitiligo? Vitiligo is hypopigmentation of skin. Patchy hypopigmentation of skin. So it cannot be the answer. Vitiligo is an autoimmune disease. That was what, for some of you that know Michael Jackson, that was what he had, allegedly. Okay, that made him finally change his skin color. All right. So option D is the answer. There's something about pellagra. Which vitamin is involved in pellagra? Which vitamin causes pellagra? What's B3? You know those B vitamins, they have names. Pellagra. So, and there's something about, there's a mnemonic, is it 4Ds? Okay, so niacin, vitamin B3. You're right, doctor, but it's niacin that is the real name. Okay, so 3Ds: diarrhea, dermatitis, dysphagia, and some people say that is the fourth one. So it causes itching on the skin, it causes itching, redness, and blistering, and diarrhea, which can lead to dehydration and other complications. Dysphagia, difficulty in swallowing, is a later stage presentation. Fatigue, headaches, confusion in severe cases, disorientation. Yeah, so that is a follow-up, a sequelae of the dehydration, severe dehydration that can follow, infection or malnutrition. So treatments can include niacin supplementation, which is the primary treatment for pellagra, and tryptophan supplementation can also be necessary. Dietary changes. So which diets? When you answer a question, it should lead you. It should, if you are curious, it should make your mind want to know the next. Like your mind should ask you another question when you read something. So which diet is is rich in niacin? That's a natural question that came to my mind when you look at that. So okay, so animal sources, basically everything you eat from beef to chicken, fish, eggs, dairy products like milk, cheese, yogurt, they contain niacin. Plant sources, legumes, whole grain like brown rice, wheat, okay, nuts and seeds, almonds, vegetables. Okay, so that's good. That's good. It's commonly available. All right. Which function is associated with the temporal lobe? That's the next question. It's a question you can even answer without seeing options. It's motor, visual, auditory, and sensory. So which of them? Have you heard about, what's the name of this epilepsy? Is it Jackson something something? Jacksonian epilepsy. So option C, yeah, auditory processing. Yeah, that's the major thing. So in Jacksonian epilepsy, it can originate from, because it's a partial seizure, it can originate from the temporal lobe. So the person will be having auditory hallucinations and things like that. So auditory aura, they will know that they're about to have a seizure when they start having hearing, you know, hallucinating sounds and all that. Okay. So the next question, this one is basic sciences, physiology. Cells obtain cholesterol via option A, phagocytosis, endocytosis, exocytosis, diffusion. So it's not bad. Have you guys seen the question?
Ah, yara 30 ne. To saura nawa kenan?
No.
Aka naira.
I can't see the whiteboard again. Are you guys still seeing the whiteboard?
Yes,
Can
sir.
you see? Can you guys still see the whiteboard with contents?
No, sir.
The one that had contents before.
You can't
No,
see it.
sir.
The other one that had a lot of content. Can't see it again. Oh. If you can see it, download it, please. Download it. There's a way to download it because I can't see it because I've exited. Download it and share it in the group. Or did somebody wipe it off or something? But if you can see that old one that had, the hearts and other things that I drew, download it, then share it in the group. Okay, it's now showing. Mm. I don't remember where I saw how to download it. I saw it somewhere. Okay. So is it that they ask this question as a common manifestation of HIV or